Thank you very much. So yes, the previous talks have been very strategic, top-down. There's obviously a lot of different stratified medicine initiatives going on around the country, a lot in asthma. I'm afraid I know about children's asthma, so I'm going to be giving a slightly more bottom-up talk, looking at a study we've done, how it worked with NIHR and MCRN as it was then resources, how the bits that worked, the bits that didn't work, and then how this has the data that's come out, where it is, how it fits with other things that are going on, and how at a national and international level these things then need to be taken forward and improved to make sure what we do actually makes a difference to patients at the far end of it. So starting at the bottom, my interest is around adrenal suppression. So we've done a study looking at children who take inhaled steroids for asthma and oral steroids, and a lot of it started through some work in Glasgow from Jimmy Payton, who found there are some children who just have very low cortisol levels when they're on steroids, and this is obviously not good for their health. There were actually a death in Glasgow which prompted all this, and then the sibling came in very, very unwell as well, and somebody realised it was the sibling of a child who died, treated them for adrenal suppression, but actually the genetic link wasn't made at that point. And it wasn't clear why there was such inter-individual variation between people taking inhaled steroids. Could it be dose, age, adherence, some other factor, genetics? And obviously we hoped it was genetics. So we set up a very generic study. We've got a common condition, we've got a very common medicine. Inhaled steroids are amongst the top 2 or 3 prescribed medicines in primary care. They cost upwards of £600 million a year to the NHS. And we set up a study that had extremely broad inclusion criteria. So we weren't looking for a subset of patients. We weren't after biomarker and stratifying the patients before we recruited them. We were interested in genotyping patients with a common condition using common medicines at the common doses that were used. So this seemed like a reasonably straightforward thing to do. We did also insist that we get some lung function tests, and I'll come back to that at the end as to why that wasn't a very good idea. But that essentially limited our study to secondary care. And that was okay. There's lots of general paediatricians. There's lots of children with asthma. There's lots of opportunities to do this. And we also wanted what we consider the gold standard test for adrenal suppression. Now this will vary around the country, and again I'll come to that in a second, but it wasn't the most challenging study to identify patients for. Our power calculation said we needed 500 patients to do this, including a replication cohort. We actually needed 600, and we ended up needing 27 UK sites. 25 of them were in England, which are marked on here, and you can see we did mostly, me being based in Alderhay, we did mostly talk to our friends. But we did spread out more broadly than that. We've gone as far as Bradford, which I was talking to Dinesh about earlier on. We go down as far as Cornwall. Glasgow did participate and were excellent, but my map cut them off. Ayr did participate but didn't recruit anybody, so I left them off. However, in terms of setting up and running as an academic-led pharmacogenomic study, this was relatively straightforward. You know, there's obviously a certain amount of paperwork, there's approvals that vary, and that the talk about R&D directors harmonising things sounded wonderful because there are different processes at each site and different routes to go through. But actually, the biggest problems weren't around research infrastructure, they're around healthcare delivery in each site. Because even with a common condition, with a common drug, and a fairly well-accepted gold standard test, there's variation between places in the NHS about how these things are delivered. When do you time your short synactin test? What dose do you give? When do you do it? And because a bad result in a synactin test would be a medical emergency, we couldn't leave these children with us knowing it and the sites not knowing it. We kind of had to rely on each site to analyse their own data and send it up to us. And then we had questions about, do all the labs do the same test? Is the margin of error for the test the same for each lab? How do we know that they timed the samples right? And a lot of those issues were where we had our headaches. Where we didn't have the headaches was DNA. People were very comfortable, even though when this was done, you know, some of the general paediatricians had never done a study taking DNA. That wasn't a problem. Provided we did a site initiation visit, provided we talked through with the teams the type of blood samples, the volumes, the storage boxes, the postage requirements, all the things that, the granular detail, actually that bit really was very straightforward. And that kind of meant that the study itself was a lot more straightforward to deliver. And we recruited. We got to our final recruitment figure of 601 in the end. Now, to me, that sounds like a lot, but I know that for a lot of genetic studies, that's actually not very many. But this is 2 years recruitment, more than, in 25 sites across the big chunk of England for a common disease. So I suppose the message there is even in situations where you think you should get a lot of patients, it's quite hard work and it needs sustained effort to deliver it. And the clinical results, well, there's an association between dose of steroid given and the number of children who had a low synactin level. Unfortunately for us, when we looked at the clinical data, those data weren't clinically significant. So while it was statistically extremely significant that the greater steroid dose you took, the lower your cortisol, actually, for every dose increment, that's 200 milligrams of beclomethasone inhaled, the change in your cortisol, peak cortisol, is less than 1, and you've got a threshold for normality of 500. So it's neither here nor there, to be honest. And we did some fancy analyses looking at whether adherence to the drugs would actually make a difference. Didn't make a difference, but it did show us that it's very, very hard to take a study from secondary care at 25 sites to the primary care who are providing repeat prescriptions at 25 sites. And we ended up actually having to just take adherence data from a very localized set of patients from around Alder Hey, because actually getting into primary care sites where we weren't familiar with the clinicians or where we were just after a repeat prescription for 1 or 2 patients to get all the approvals was a sheer volume of work that we couldn't take on for an academic-led study. It also showed that children with asthma take a really, really variable range of drugs, and quite how you'd need 2.5 times the number of inhalers unless you're sharing them around your family, I just don't know, but that's a separate. So having collected all these data, there was nothing clinically that was very relevant to us, and we did our genetic analysis and moved forward. Now during this time, extra information came out, and while 500 is still normal, it became very clear that what a normal cortisol is in a child is very difficult to know, because if you have to stick a needle into them to measure a cortisol, they get stressed, and stress then raises their cortisol, and you don't know where you are. So salivary cortisol seemed to have helped here, and we now have a threshold for these children below a peak cortisol of 350 are much more likely to have adrenal suppression and symptomatic illness. So we've gone and undertaken a genome-wide association study with this population. With the eye of faith, I promise you in chromosome 11 there's a reasonably nice stack here, and it didn't quite reach significant population significance, genome-wide significance for the discovery cohort. So this is just children with asthma from our past cohort. But we did 2 analyses, one of 500, one of 350. 500 because we said we would in our protocol, 350 because the data said it was probably a better value. And actually one gene came out in both. And there's some background scientific work that gave it credibility. And we replicated it. So another group of children were recruited, or part of that 600 we used as our replication cohort. And you can see there's a progression. So this is, the GG is the homozygous mutation, heterozygotes, and then homozygous wild type. And there's an increase in your serum cortisol on steroids for the wild type and a decrease in the variants. We also repeated it in a population of elderly patients as well, who had COPD and took inhaled steroids for that. And I think that's when we started to get much more excited, because the same gene was also replicated in both. So if you look at our forest plots, these are the 2 children's asthma cohorts. There appears to be a relationship between this particular polymorphism and platelet-derived growth factor D and adrenal suppression. Even if you add in the old people with COPD, you've got the same relationship coming through. So that's quite exciting. But how do we then, and we then had to prove that it wasn't just a gene related to how much cortisol you make. And so we worked with a team from Edinburgh who had 25,000 people with early morning cortisols and showed that it wasn't related to steroid-naive patients, which was very reassuring to us. So we've got this lovely finding that we have a new genetic polymorphism. We've delivered a study across the NHS delivering patient numbers, but how does it impact in sort of pharmacogenomics and delivery of work? And if you look at pharmacogenomics in childhood asthma, and I can't speak for adult asthma, I'm afraid, there are lots of publications. The first ones came out in about 1997, so we've got more than 20 years of data, but not a single pharmacogenomic association is in any international guidelines for the management of asthma. So there are thousands and thousands of children who've been through these studies, but we don't do anything differently because of it. And that's a problem. Partly that's because individual studies are small. I'm quite proud of 600, but that's not very big overall. Partly it's because replication has been very difficult. There are completely contradictory results. If you look at the beta-2 adrenal receptor data, apparently one polymorphism if you're Puerto Rican does the opposite if you're Mexican. And that doesn't make any sense. Partly it's, and yeah, they're the main reasons. So actually, as a cause for hope, yes, we need our national structures to be able to deliver these studies, but we also need to make sure that we work internationally to be able to generate the patient sample sizes to get the answers that, or to find out what the real answers are. In our case, we have the PICA consortium, Pharmacogenomics in childhood asthma, and that's about 20 groups, that should be an about, not no greater than, sorry, who have all recruited cohorts, and they've all put their data together, and we do, the idea is that meta-analyses are agreed and carried out using the highest grade evidence and criteria. And it has multiple different ethnicities in it as well, because actually, when you look at our past data, it's almost uniformly Caucasian. Well, that doesn't help the vast majority of the people in the world who might use this information. So this helps solve that. And when you start to put this together and we start to analyse it, actually, yes, there are 50 plus publications. Yes, it's taken 20 plus years, but now the nuggets, the little diamonds are starting to emerge. There's a beta-2 adrenal receptor polymorphism that, if you meta-analyse it with use of long-acting beta-2 agonists, and this is 637 patients who use beta-2 agonists, long-acting beta-2 agonists, out of a population of 4,500. So now we're talking good numbers, and you can see your risk of exacerbations if you give somebody a LABA and they've got this genotype is raised, and it's quite significantly raised, 1.5 times the number of exacerbations. If you give them a leukotriene receptor antagonist, it goes back to normal, baseline. There's another one in steroids which is related to response. So we're starting to identify the key facts. Where I think we've got some work to do is around which facts we look for. So there's been a very heavy emphasis on benefit. Does the drug work? Not does the drug cause harm? Now clearly I'm biased in this, I like adverse drug reactions, but I think that's fairly true. And we've done a systematic review that we've just sent out. Of all these studies in childhood asthma, of all the primary and secondary outcomes that have ever been looked at, there are only 5 that are related to adverse drug reactions. So that's a very, less than 10% of the studies, but of all the outcomes, that's a very small proportion of all those outcomes considered. But when we've surveyed PICA, everybody says, yes, we should do this. So I suppose at least we're raising awareness and making progress. And we've now got a survey across the international community highlighting which drugs and which adverse drug reactions should be considered. So it's now hopefully more in people's minds. The final area where I think we can improve is our outcomes. So we collected data on respiratory function in these children. We've never published it because it didn't mean anything, but there is a core outcome set for children with asthma. Develop properly, whole Delphi process. Children care about whether they feel all right. Children care about whether they go to school. Children care about whether they go to hospital. Children care about whether they're up coughing all night. They don't care if their FEV1 is 5% different. Okay? And children have healthy lungs for the most part. So when they're well, they should be completely well. They shouldn't have the damage that adult asthmatic patients would have. When you look at the outcomes used in pharmacogenomic studies, and this is just short-acting beta-2 agonists, all the orange ones are FEV1, which are meaningless to us as paediatricians. So perhaps part of the barrier in terms of delivery and implementation is that actually what we have measured because it's easy to measure is not what clinicians value in terms of is it going to make their patients better. So looking forward, at a national level, delivery of study worked reasonably well. There are hiccups, there are variations, but actually that wasn't the bigger problem. The bigger problem is getting critical mass, even in a common condition and even with common drugs, and getting the right outcomes to ensure that actually international guidelines will start to reflect these changes. And we're not quite there yet, I think. Thank you.